Welcome everyone. My name is Adelina Comas Herrera and the Director of the Global Observatory of Long-Term Care, and it is my pleasure to welcome you to this webinar. I'm going to quickly tell you a little bit about the observatory, just in case you didn't know, and also so that you're aware of all our future webinars as well. The Global Observatory of Long-Term Care is a platform for cross-national learning to improve and strengthen care system, and it's part of the International Long-Term Care Policy Network. Our aim is to identify key shared challenges, showcase how different countries and localities are addressing them, share research evidence, and facilitate collaborations. And it's open to everyone. We're thinking of policymakers, industry advocates, care professionals, and of course, academics. To become a member, it's free. You just need to join. And once you join, you can also choose from the different interest groups. We already have 22. So I think we have a really interesting and varied offer. And here you will find people with similar interests. We are also very happy to share your publications and events. You can send us an email for that. And you can share your knowledge in many different ways. We have topic guides, country profiles, methods guides to blog posts, and of course, presentations in the webinars of the interest groups. This is how to join, so very big. And I think many of you are possibly members already, but always good to say. Also to let you know about our next webinars on the 10th of February, we have one of the Employment, Education, Family Carers Interest Group, and that's on work-life balance for informal unpaid carers. We then have one on the 18th of February from the Global Perinatal Mental Health, looking at STEPS and mum mood booster in Australia. We then have one from this interest group, from the Care Home Markets and Regulation Interest Group, who is hosting us today on accountability mechanisms in nursing home services. And this is from some research from Spain. We have on the 3rd of March, a quality in long-term care webinar looking at frameworks and approaches for assessments and improvements, hearing a presentation from the new WHO long-term care framework for assessment and continuous learning. And back to this interest group on the 17th of March, we'll be hearing about ownership, asymmetric information, and quality of care for the elderly. And that's evidence from US nursing homes during the COVID-19 pandemic. So as you can see, we have a lot of webinars planned. We have a great start of the year, and we're delighted to welcome Igor from this interest group, who is going to introduce today's webinar.
Thank you, Adelina. Just give me a second to launch my slides. Dear colleagues, I'm pleased to welcome you to the 3rd webinar of Care Home Markets and Regulation Interest Group of the Global Observatory of Long-Term Care. Thank you very much for joining us. My name is Sigurd Shagalov. I am the group lead. And if I may, I would like to say a few words about our group. So the ambition of our group is to support knowledge exchange about regulatory and market shaping policy to improve the quality outcomes of bed-based care by open collaboration between academics, policymakers, practitioners, and providers. We pay special attention to the potential and limitation of different ways of organizing care markets and their impact on care outcomes and costs. And to this end, the group will organize regular webinars to share relevant evidence and create a platform for live discussion among international experts. However, we don't limit ourselves to these topics, and we endeavor to disseminate the knowledge gained from the group's work beyond its boundaries, and our group will be happy to post your publication, as Adelina has already mentioned. And yeah, how can you do this? How can you join our group? It's very simple. Very briefly, a couple of slides about that. There are simple steps. The first step is to register on the observatory website. The link can be seen on the screen. The second step is to tick the box for our group during registration. And finally, the optional third step, if you already registered on the observatory website and you would like to join us, you can simply fill out the application form on the group page itself. And of course, we look forward to having new members in our group. And you can also send us any questions or any concerns about the work of the group and participation in it to the emails presented below. And we would appreciate it if you could share with us ideas for future webinar topics that you would be interested in considering. And you can do that in the chat during the webinar or by email. And now, finally, a few words about the composition of our steering group. It includes Jose Luis Fernandez, the director of the Care Policy and Evaluation Center, Adelina Comas Herrera, assistant professorial research fellow, Care Policy and Evaluation Center, and I, Igor Shagalov, research associate at the Care Policy and Evaluation Center, a research fellow at the University of Birmingham. So our group is growing now with 87 experts working in more than 30 countries around the world, and I think it's a good sign. But we also would like to increase the representation of our policymakers and care professionals in our group. So if you know of such people, we would be very grateful if you could tell them about our group and invite them to our next events. So now let me say a little about the topic of today's webinar. There are contentious debate in academic and political circles about whether marketization and private sector involvement has worsened the crisis facing adult social care. And today's webinar and our speakers contribute to this discussion and understanding the pros and cons of privatizing social care. I think it is also a good opportunity for all of us to talk about the prospects for private sector and how industry regulation can be organized to ensure that the necessary care quality standards in care homes and well-being of older people. Now we are very pleased that Anders, Benjamin, and probably Michelle from the University of Oxford have agreed to present their paper today on the forced closures of care homes in England and how these closures relate to ownership status. And I would like to turn the floor over to our dear speakers, Benjamin, Anders, please. And yeah, one more point before their presentation. Benjamin will join the LSC very soon, so and we'll be have time to speak about all of these issues properly. So that's great news. Okay, yeah, please, Benjamin.
Yeah, thanks.
The floor is yours.
Yeah, I'm desperate for new friends as well around LSE. So if anyone is knocking around London and wants a coffee, please do reach out. That'd be good. So thank you very much for inviting us to present today. It's really nice timing for us for a few reasons. We are, as a team, starting to sort of build out our arguments that outsourcing is maybe contributing to a care crisis. And we're going to be spending the next few years sort of developing sort of more robust and rigorous analytical evidence towards that. And so any feedback we get is going to be so useful for us over the next couple of years as we start to do further research on this. I've been invited to present sort of with Anders and Michelle, or on behalf of them, to talk about forced closures of care home in England and how that breaks down by ownership categories. But I want to start by introducing you to View Park Care Home, which is a large care home up in Manchester, about 80 residents. It was forced to close in 2019 after the CQC decided it was an unsafe care home. The latest inspection described it as unsafe, largely because the care plans of residents weren't being adhered to. The examples they gave were there was a resident who needed their sort of fluids thickened so that they wouldn't have a sort of choking hazard, and that wasn't happening. They described residents not receiving enough liquids at all, so being dehydrated, and there were residents who had on their care plans a need to be assisted with changing positions in their bed to avoid ulcers, and that wasn't happening either. Alongside that, there was a whistleblower from the staff who were complaining against the leadership of the care home that had been treating the staff unfairly. and the care home had a couple of break-ins in the last couple of years, including a safe with residents' belongings being stolen, which hadn't been replaced by the time the CQC went to inspect it. So all in all, they decided this home was not safe for the residents and had to be closed down. View Park Care Home is owned by a company called View Park Care Home Limited. It's a family-run small business. If you look at their board of directors, they all have the same surname, so a nice independent family business. The director is a trained medical professional, but if you have a look through the other companies he owns, one is called Beachlands Care Home Limited, which was also closed a few years earlier. And then you have a Google of that, and you find that that was also a failed care home with public atrocities reported in the media. So there's a bit of a cycle here with this director. You have a look at the other companies that the director owns. He runs an investment company. I can't remember the name, but it's something like Make Money Limited, and owns and runs an estate, a real estate company too. A month after the final inspection of View Park Care Home, a brand new care home company is registered at the address, and I can only speculate what that was for. I think it came to nothing, but this process of failed care home and just the family setting up a new care home company seemed to be something that they were at least exploring too. And the property was sold in 2020 for hundreds of thousands of pounds. I also want to introduce you to Morecambe Bay Care Home, which is another large care home of around 80 residents. But that one was forced to close in 2017, but primarily for the reasons of the way they managed the drugs. So when the CQC did their last inspection of this care home, they found that around a third of residents weren't receiving the drugs they were prescribed because they were out of stock. One example they gave was a resident who had laxatives prescribed for them daily that hadn't received it for over 20 days because they were just not available to them. This, along with issues around falls and the attentiveness to residents that had had falls, meant the CQC forced this care home to close too. Morecambe Bay Care Home is owned by Four Seasons, and I imagine some people here know the story of Four Seasons pretty well, but it goes something like it was the largest provider of care homes in England, with at one point owning over 500 care homes. The ultimate ownership of Four Seasons was passed from private equity to investment firm over a period of 15 years, where the company would be loaded with debt, stripped of whatever profits that could be made of it, and ultimately it defaulted on the debt and entered administration in 2019. I think this year they're still sort of selling off their last care homes. I was reading in the Financial Times a sort of summary of the memoir of Guy Hans, who was the owner of the final private equity firm who was running Four Seasons when it went into administration. And he described the most difficult period of his life was when he decided he had to move to Guernsey to avoid tax because he didn't believe in paying tax in the UK. But his wife and children refused to join him. And so he had a really difficult period of separation of his wife and kids, but he knew that he had to do that to avoid paying any tax. So then our research agenda is really trying to link these two things. Does it matter who owns care in terms of the quality of services provided and how? In a sort of policy framework, the way that we think about this is, does the outsourcing of care to the private sector correspond with better or worse outcomes for the people receiving care? Despite the vignettes that I've just given you, the way that me and my colleagues primarily do this is sort of quantitative analyses using ideally big open data. Sometimes we resort to freedom of information requests, which is where the data we'll present to you today comes from. And I think it's nice for us to, whenever we're presenting our work, start by acknowledging that even if ownership matters in care quality, we are aware that we are studying a context and a period of time in which almost everything in England got worse, and not all of that is going to be as a result of outsourcing or ownership. And whilst we have austerity and increasing need, perhaps outsourcing makes these problems more difficult to solve, but isn't the sole cause of care quality. So the reason that this presentation is really nicely timed for us is because the context of this research is that we have been funded in two parts to do bits of work. The first, which we've just completed, which is where what we're presenting to you today comes from, is that we were funded just to aggregate as much data as we can on the levels of outsourcing and privatization and measures of quality, and to then descriptively analyze these and present them in very simple analyses to measure the levels of outsourcing and corresponding quality. But what's nice for us is that we've then been funded for the next 2 years to then do the more sort of causal inference, policy evaluation style analyses, where we'll be looking into the more sort of inferential statistics of the relationships between outsourcing and care quality. And so any feedback you give us today would be super useful as we develop this research further. So what does our data look like? We try to collect primarily data on the levels of outsourcing and quality of care. For outsourcing measures, we try to get 3 different things. Expenditure data, what do local authorities spend on care and in which sector? Activity data is what number of hours of care are given by whom? And provider data, which would be what care homes exist in England and who owns them. And then our measures of quality are sort of many different ones, but the ones that we're presenting today are the ones from CQC, which include inspection ratings and regulation outcomes. So some of our data can track the sort of level of private sector involvement in long-term care. On the left, we have our measure of activity levels in the private sector. And so this is just the number of hours of care, the percentage of hours of care that are delivered by outsourced residential settings. You can see that in 2020, we have around 75% of residential services provided by the private sector, whereas by 2023, that's almost up in 90%. Each blue dot in that left-hand graph represents a local authority, and you can see that there is quite a lot of variation there, with some local authorities a lot lower. But by the last couple of years, it's really only the outliers that are sort of lower than 80% outsourced services. And then on the right, we have our graph of our provider data. And what's useful here is that we can show that whilst there's been this push to outsource services, the vast majority of that has gone to for-profit sector as opposed to the third sector. In fact, charities running care homes are actually having their sort of relative share of the care home market decline year on year, even though we're having this push towards outsourcing of services. Our data also shows inspection rating results. This is just a very descriptive analysis, but what we've done here is plotted the percentage of inspections within each sector that are rated as good or outstanding. And then we've plotted those as rolling 365-day periods. So at any one point on this plot, the way you can interpret it is that around 60% of inspections done in the for-profit sector over 365 days come out as good or outstanding, whereas for local authority and third sector, that's around 15% higher and around 75%. This is sort of visually what people might describe as the for-profit gap in quality, where the sort of profit motive is cutting costs and therefore delivering worse quality care. You can see that when we hit COVID, after that 365 days in 2021, the sort of inspection regime changes quite a lot. But when I last updated this data in the end of 2023, maybe it was sort of returning to what we considered to be a normal of this underperforming for-profit sector. So one way we might want to interpret this then is something like this push to outsource services, which has led to a domination of the for-profit sector, might well be corresponding with worse quality care on average, as the for-profit sector is simply underperforming the rest. But I think there are also lots of reasons why this is a insufficient analysis, even if you were to do it sort of robustly with sort of regressions and controls and stuff. And some of those reasons are that we might not care that much about average quality differences. So CQC inspections have a 4-tier rating system, right, between outstanding, good, requiring improvement, and inadequate. And if we did a sort of ordinal logistic regression, and we see that the for-profit sector is on average lower in that ordinal measure, it might be very important to us substantially whether that worse ratings are between outstanding and good and requiring improvement and inadequate. Like that just might matter a lot for the experiences of care that people are receiving. And I think that sort of leads to this point that sort of quality and measurements of quality are sometimes not that meaningful, particularly with inspection ratings, where they might often not reflect resident experiences. The experiences of residents in care home might vary a lot, even within the same care home. They might relate to things that aren't inspected, and it might be the case that inspections themselves are not good ways of observing what happens in a care home. And so then what we're really after is a measure of quality, which can have some sort of personal implication and can have some sort of direct measure on something that is on some sort of extreme scale of quality, which is where forced closures come in. So we're operationalizing forced closures as an extreme form of poor quality care, of service failure. And the reason that we're doing that is because this is the sort of last resort of the CQC. The CQC will only force a care home to close if people have suffered harm, at risk of suffering harm, or they're receiving care services that substantially fail to meet the standards set out in the regulations. And I think there's sort of a few interesting things to say here. For me and my colleagues, we are probably sort of using this as a sort of negative measure of service failure. You know, the more of these that happen, the worse it is for the sector and for people. But there might be some people for whom think sort of purely in how markets are supposed to work and consider that having a sort of churn of services, a churn of providers, and having those that fail drop out of the market is actually a sort of ideal type of public service market. It might be something interesting for us to discuss at the end. But anyway, we thought this would be a sort of useful measure for us to fold into our data. So we get in touch with the CQC, who have always been very good to us, and say, can we have access to all the care homes that have been forced to close since 2011? And they said, here you go. And it looks a little bit like this. So here we're plotting the number of care homes which have closed in every given year relative to the number of care homes which are closed for other reasons. So care homes that are just sort of closing to their own accord, not because the CQC has forced them to shut down. And you can see that in any given year, there's around 100 care homes being forced to close down by the CQC, which makes up around 10% of all kinds of closures. In total, we have just over 800 closures over the 10 years. And it corresponds to, I think it's a little bit less than this, but roughly sort of 1 in 30 care homes in England being forced to close down since 2011. So we then analysed this data, we folded it into sort of the registry of care home data that we have from the CQC API. And we had a look at comparing the sort of characteristics of care homes that are forced to close compared to those that are still active. And we can see that the care homes that are forced to close are sort of unsurprisingly more likely to be rated inadequate. Almost all of them were sort of rated inadequate in their last inspection rating. Some were rated requires improvement, and some were even rated good, but very, very few. Perhaps also unsurprisingly, the care homes that were forced to close were disproportionately new, so recently registered. And I think that could be two things. The first is that it's sort of a selection bias and feature of the data that care homes that are still active as of 2023 are likely to be older than care homes that were closed in the past. But also maybe hinting at this idea that sort of new innovative providers are more likely to be the ones that fail. When looking at the services that the care homes were registered to provide, the care homes that are forced to close were disproportionately not registered to serve disabled residents. But interestingly, for all other resident types, they were pretty similar to the active care homes. And then what we were really interested in looking at was the ownership breakdown, which looks a little bit like this. Myself and my colleagues have been analyzing sort of relationships between ownership and outsourcing and different outcomes for a long time. I don't think we ever expected to have a relationship as strong as this, where you have 816 observations of something happening, of which almost all of them happen in a for-profit setting. So 804 out of 816 forced closures happened to for-profit care homes. In the graph that we're showing here, the top panel is the percentage of inspections that are rated as inadequate. So this is just inadequate inspections. And you can see that the for-profit sector is overrepresentative of inadequate inspection ratings relative to third sector and public. But that difference is much, much larger when we then start looking at forced closure in the bottom panel. And this builds out our argument, which is something like the difference, that gap in the for-profit gap in quality becomes much larger the more extreme you look at poor quality measures. And so some interpretations we made from this data, which we are just presenting sort of descriptively, is that when things go really wrong in care, it's almost always in a for-profit provider. And so this sort of gap in quality gets larger and larger the more extreme the measure of quality you look at. And then we might want to make a sort of cautious interpretation that this push towards outsourcing, where we folded in for-profit providers into delivery of care services, a consequence of that could be that we are increasing the risk and the probability of residents receiving really terrible care. There are, I think, lots of reasons to be cautious about this. The first is that we don't know for sure that what's underlying this relationship is sort of quality of care. Anders and I published a paper on children's care homes about 3 years ago, where we showed sort of very similar results. For-profit children's homes get worse ratings, they break more laws, they're worse on average. And we saw some feedback from sort of the for-profit representatives in the sector saying, this is this is just Ofsted being biased. Like this is Ofsted just treating council-owned children's homes much better than they treat the for-profit sector, where you have these sort of tensions and aggravations, whereas they're going to work with the council homes in a much more sort of harmonious way. And I think the same could be happening here. I'd be interested to know if anyone's got experience of that in this room. Could it be the case that when things go really wrong in a council care home, the CQC doesn't force it to close, but rather works with the council in a way to try and sort of be more cooperative. Another interesting thing in the data is that the sort of disproportionate level of forced closures in the for-profit sector was only really true for sort of partnership and individual settings. So it wasn't true for chains and large chains. And so then a narrative that you might want to draw about the sort of profit motive, cutting costs, cutting corners, meaning that residents are treated really poorly, might not necessarily fit the data, because that profit motive is most likely to be most extreme in those large chains. And so then we're looking at something that's sort of a mix of sort of risks that are involved with sort of small, inexperienced providers, mixed with the sort of profit motive in the private sector in general. Another thing that sort of myself and my colleagues are being considerate of more generally, not just in this paper, but in all of our work, is that some of the feedback that we're getting is to say, okay, so you're presenting results which say that outsourcing might be sort of corresponding with worse quality care, but I remember a time before we had outsourced our services when the councils run care homes, and it was bloody awful. And so I think this is something that we are sort of genuinely intrigued and interested in, as to whether, if the counterfactual is what experiences of people in care were like before we outsourced services, was it better at all? And if not, what does that mean for the kinds of analyses we're conducting? So then how does this fit in with our sort of wider research findings? Myself and my colleagues are trying to build out this argument that outsourcing corresponds with worse quality care, less accessible care, and less equal care. And we have a number of different findings, which we've either published or in the process of analyzing or publishing at the moment. And you can see that, so for our worst quality care is sort of the things that I presented today around more forced closures in the private sector and lower ratings. But we've also got findings around the sort of locations of care homes, arguing that sort of for-profit sector are more selective about where they provide care, which are going to be potentially contributing to issues of care deserts. We're also analysing at the moment data we have on evictions. Again, thinking about this angle of accessibility of care to individuals. And then we've also got a strand of research, which again, we're publishing at the moment, where we're looking at the sort of funding status of individuals in care. And we can see that for-profit homes have sort of inequalities in their quality of services according to the area they're located and the percentage of self-funders in their home. These are inequalities which actually don't exist in the third sector and local authority homes. And so again, we're building these arguments that more outsourcing means more for-profit providers, which means more of these issues around accessibility, equality, and quality. And the reason that I sort of put this slide is because I'm just wondering if this is a sort of provocative argument for people in the room. We've been getting, I guess we're always going to get mixed feedback, and that's fine. But some of it has been maybe a little surprising in terms of where it has come from, in terms of like criticism of this narrative. And so I'm putting this here just to maybe provoke some people and get some reactions as to whether this sort of narrative and argument and these findings that we're presenting sort of reflects people's experiences of care, of working in the sector, or whether we've missed the mark some way that you can help steer us towards. So then some concluding thoughts. Markets hail failure as a sort of positive form of competitive selection. You know, this is sort of part of the intention of a marketized care service. You have providers which come in and fail, and that is part of this spiraling towards success and improved quality through competition. But it might be the case that in long-term care and residential care, that it's just not worth the price. What we've presented today potentially represents 19,000 people who experience first risks to their safety, followed by a serious disruption to their care, either by their provider changing or by having to sort of move home entirely. And so this snapshot that we've presented of care failure perhaps suggests that marketisation leading to the for-profit domination of care has worsened care at the extremes. Thank you very much for the chance to present.
Thank you very much, Ben. What a thought-provoking presentation. I'm sure it will be a question-provoking as well. I'm José Luis Fernández. Will be chairing this discussion part of the seminar. We've already got one question on the chat, so I would suggest if you want to ask questions, raise your digital hand. I can see 2 hands already up. But Diane, would you like to very quickly introduce yourself and ask your question? Diane Burns.
Yeah, thank you. A really, really interesting and insightful presentation, Ben. I really enjoyed it. One of the things I was thinking about with your possible theories, conclusions that you're playing around with, was whether, well, one, are you arguing that all outsourcing is potentially the issue? Or is it that because we've always had care homes that have operated outside of local authority outsourcing, so is that the issue in and of itself, or is it more nuanced than that? And I was thinking that of those care homes that were had enforced closures from the CQC, whether those care homes were contracted by the local authorities, and to what extent, so what proportion of the people living in the care homes were funded through a local authority level fee, and whether you think care homes that have a cross subsidy of income, LA fee, plus self-funders who pay a much higher rate can have a stabilising effect on quality. Because obviously those commissioned by the LA, the argument is that it's underfunding and it destabilises destabilises a particular organisation's financial stability and potentially the market. Sorry, that was there was quite a few things in there. Sorry for that.
Great, it gives me the opportunity to just answer whatever I want to. So thank you.
Yeah.
So we've done a little bit of work on this sort of cross-subsidy question that you're raising. And this is a paper that it'll come out in the next few months, where we're looking at the quality of care homes according to the percentage of residents in the care home that are self-funder versus state funder. And so what we see is that if you're in sort of local authority or third sector owned care homes, you're going to receive sort of relatively good quality care, regardless of that cross-subsidy percentage. If you're in a for-profit care home, if you're in a care home that's largely tailored to the self-funded residents, then you'll receive good quality care. But actually, those care homes that are in the for-profit sector and largely serving state-funded residents, these are the ones where you're getting sort of poor quality care. And so, yeah, we can break it down. We never linked it to our forced closure data, so I can't answer the question as to whether the homes that were forced to close are those serving local authority residents. I would say that I think based on the data, almost every care home serves some local authority residents, so they will be in some extent contracted by the local authority. But yeah, so the cross-subsidy matters, the number of self-funders matters, but actually only matters for the for-profit sector is what we found. As for the sort of nuance of, is this all outsourcing is bad? Obviously, it's the case that the for-profit sector sometimes has really good care, and this is not an absolute thing, that for-profit providers are always worse than third sector. And I think the sort of way that we would try and word it is something that the way in which that we have outsourced over the last 10 years has not corresponded with the best care homes surviving, and has not corresponded with sort of the best quality services. But yeah, I don't know if that is a sort of satisfying answer or not.
I think it was a very thorough answer. Thank you very much, Ben. Next, Simon.
Yeah,
Bott.
thanks, Ben. As you say, really interesting presentation. The question I had, it links actually to the question that Diane had, which is, I wonder whether there's a sort of alternative complementary interpretation of the data, which is essentially that that where homes have the capacity to subsidize themselves, then they're able to provide better care. So the not-for-profit sector will often subsidize the way that it runs its care homes. Either, for example, it may fundraise for the building cost, or it may actually support the running cost out of charitable funds. And I used to be policy director at an older people's home charity a few years ago, and we subsidised our homes, 3 homes, to the tune of £1 million a year in order to maintain the level of quality that we wanted. Local authorities, the cost of providing a home, the stated cost, is something like double the cost of the for-profit sector. So essentially, the not-for-profit and local authority sector essentially are subsidising the cost of their homes in order to maintain a level of quality. Whereas if you're a for-profit operator, you have to make a profit. That's the nature of your business. You can't make a loss. So you don't have that option available to you, with the exception of where you're part of a large chain. And if you're an individual home that runs into difficulties, you can actually a chain can put more resources into that home that's running into particular difficulties, and that might explain why I think you're finding that closures apply particularly to partnerships or single homes rather than chains. So basically, the amount of money that you put into your home, you're able to put into your home, may be the determining factor of the level of quality that you provide, I guess, is what I'm thinking.
Yes, yeah, really useful thoughts. Yeah, this idea that ability to absorb sort of shocks financially potentially is different too, in terms of yeah, those sort of individual and partnership chains, once things go wrong, don't really have any sort of fail-safe other than sort of failure. That's a sort of nice interpretation. Yeah, thank you, Simon.
Thank you very much. Next, we're going to go to the chat, and Lyron David, you've put a question there.
I don't know the UK law so well, but I wanted to know if the coming Public Procurement Act changes will influence this regime of community of care of older persons, and do you think that there can be a comparison between profit and non-profit in a way that can direct the behavior? And then maybe if the contracts or procurement or regulation will prefer in some way charities, can that influence the field of the care homes in a way? So to take like the corporate legal aspects of the behavior.
Maybe you can explain a little bit more where are you going along the lines of sort of procurement regimes changing towards giving sort of more flexibility for commissioners to not have to go through sort of competitive tendering and
yes, and to prefer maybe non-profit if the database show that they work better in the care homes.
Yeah, I think so I'm not sure about sort of non-profit charities in terms of whether local authorities have preferences with them or not. I think something that's kind of interesting in our data is that the last couple of years, we actually see a slight uptick in the amount of sort of council-owned sort of care home provision. And I think this is true too of the children's care sector, which we work a little bit in, where councils are maybe starting to turn back into sort of insourcing some of their care. And so it's not exactly what you're asking, I don't think, but I think it might be the case that we start to see over the next few years a sense that councils are sort of coming to terms with some of the failings of outsourced services and responding to that via building sort of capital in-house. And I think they obviously haven't been able to do that for the last 10 years because they haven't had the funding to do so. But at least in the sort of children's social care sector, that's the main argument for starting to build in-house capacity, is that sort of financially, this is a very costly sort of.
So in the children area, they prefer non-profit?
Yeah, they're starting, a lot of councils are starting to build their own children's homes again. And one of the main reasons for that is that it's been a very expensive, it's gotten to the point in which a lot of the provision by private providers is costing too much to them. And I think we're going to see, or I think we're starting to see some of the same things in the data with the long-term care data of this slight change towards in-house capacity. And so I think that's going to be one lens through which we can start to analyze, is there a sort of revealed preference of councils towards sort of non-profit forms of provision? But we'll see. Yeah.
Thank you.
Thanks.
Leonid Polchuk.
Yeah, thanks. Thanks, Ben. It's a great presentation. A bit surprising, if I may say, and I'll explain why. But first of all, if I may, I would like to comment on the previous question real quick. And that is that you cannot rely on nonprofits massively because nonprofits are subject to capacity constraints as opposed to for-profits. And one of the biggest advantages of for-profit service delivery is that you have access to virtual unlimited capital market. And secondly, nonprofits are not necessarily white knights. There are lots of evidence of abuse of the status of nonprofit, not so much for tax break purposes, but also because nonprofits in general have a better reputation. And sometimes entrepreneurs deliberately choose the nonprofit status to look like a nonprofit, whereas in fact they're out for making money. Procurement might not also be an answer either, because it's quite difficult to specify the requirements of service delivery, because much of the aspects of service delivery are non-measurable, non-observable, and for that reason, procurement might not be. And so now to my questions real quick. The first one, Ben, how much confidence do you have in quality measures of CQC? Because there is a big literature which makes people very skeptical about the efficacy, accuracy, relevance, and so on of the quality measures. And our analysis of US nursing homes during the time of COVID, which I believe will be presented here soon, showed that the mortality rate in US nursing homes over the COVID pandemic was very strongly positively correlated with quality ratings of these nursing homes, and that's what I mean positively correlated. In other words, the better were the results on the surface of your service delivery, the more deadly a nursing home was for seniors. But the most intriguing part of this presentation, and I'm nearly done, is that as Ben said, you run a make money corporation, offer a quality care for elderly, and then you are forced out, and that's like a capital punishment for a private business. And we would expect that that should never happen because people lose money big way. Most of the concerns about for-profit service delivery is that you maintain your operations and there is lingering low level of quality which is not observable, which does not lead to these egregious outcomes. So how on earth these for-profit nursing homes can afford to be forced out of business? Does it mean that they don't make much investments in this business? So bankruptcy closure is a little like Donald Trump's business model. You drop a business and you move on to another one and you make a lot of money. Or your presentation reminded me a metaphor from the political science, which was introduced by Mansur Olson, well-known political scientist. He distinguished between two types of authoritarian regimes. One was known as stationary bandit, another one was known as roaming bandit. So roaming bandit takes care of some jurisdiction, ravages it, and moves on. And stationary bandit exploits this jurisdiction for a period of time with quite some impunity. So why do we see so many roaming bandits in nursing homes industry? What makes it so vulnerable to this kind of exploit? Thanks.
Thank you.
Yeah, thank you so much. For the first part of your question, I think I sort of hate CQC ratings as much as anyone as a sort of measure of quality. They're incredibly blunt and it's sort of meaningless until you start looking at the inspections themselves and starting to sort of pick out what they've found on the days that they've rocked up. We have also, as part of our project, collected mortality data, and so over the next year or so we will be folding that in as our analysis. Yeah, pretty shocking, that finding you share about it being positively correlated with inspection ratings. And it'd be fascinating to see if we find the same stuff. I think my gut assumption would be that that CQC ratings aren't positively correlated with mortality rates, but yeah, fascinating. And I'll be at the webinar to hear your research presented. As for this sort of churn of providers, and yeah, this director who just kept opening up new companies. I'm not sure where the massive losses would come in terms of these are potentially individuals with sort of lots of access to assets to sort of buy up residential buildings and open up these companies in. And so when they're forced to close down and they're just opening up a new one, the sort of cost to them of doing this, yeah, I'm not sure that it makes so much sense to me that this is a sort of impossible feature of the private care home market, because the sort of capital of the building is probably a lot of what the sort of company rests on financially, and at the end of the day they still have that to sell off at the end. But yeah, maybe I'm wrong, and it's good for us to think about. Thank you.
Thank you very much. Then two brief questions, please. One, Catherine Schulman.
Thanks so much for the presentation. Really very interesting. I guess my question or comment would be, are you distinguishing between different kinds of for-profit providers? I think Simon alluded to this also. big chain companies that are backed by private equity funds or venture capital funds operate very differently than smaller businesses, and with potentially, there is a growing literature, especially from the US, but also from other countries in Europe and elsewhere, Canada, that demonstrates that that they operate in very different ways with very different bottom lines, and can have serious impact on the way that the firms that they buy out are run, and what they emphasize in terms of care quality and so on, working conditions. So just very different. So I think there's something to be said about thinking about the different kinds of values that different types of for-profit companies operate within. So thank you very much.
So we are looking at different types of ownership models. One of the things we're looking at is where ultimately providers are owned by investment companies and foreign ownership. Here is something we've looked at for children's homes, but we'll be producing this for care homes too. And here I'm just plotting the profit margins. And it was sort of remarkable to me that this fully worked as a sort of sense check, that the profit margins of investment-owned companies were sort of on average 20%, and foreign-owned was 20%. But the other for-profit companies, you can see how differently they are acting financially. So yeah, this is 100% sort of some of the direction that we're going in, and watch this space.
Thank you very much. And so a 20-second question from Sam Rigman.
Hiya. Thanks for that. It was really interesting. I also have to go at 2, so yes, 20 seconds. I was just wondering, I was thinking about the interpretation, and I thought lots of different things, and then I thought all of my problems with interpreting this are I don't really understand the difference between voluntary and involuntary closure and how much discretion a care home has. So, you know, if basically CQC says you're going to be involuntarily closed, can they say, oh, please don't involuntarily close us, we'll just voluntarily close instead? And then technically, you know, that's the question. What are the rules about involuntary closure?
Yeah, I think you're right. I think a care home could effectively sort of preempt this and voluntarily close beforehand. And so yeah, so maybe what we're looking at is a sort of selection of stubborn providers. Yeah.
Right. Thanks. That's interesting. Thank you.
Well, thank you very much, Ben, and thank you very much everyone for your questions. We have reached the end of the seminar. So see you soon at the next seminar.
Thank you very much. Thank you.
Thank you.
Bye-bye.
Bye.